Thank you.
Thank you, Dr. Anwar, and thank you, Sridhar and Monica and all the other organizers, and to Yasser for putting all this audiovisual things together. It's really a pleasure to be here with you all. So the topic for today is BPD-associated pulmonary hypertension, and like beneath in the previous talk, if you need to contact me for some questions later, you have my email at the bottom of the screen. It's very simple. It's just ambal@uab.edu. So feel free to email me anytime. So let me go to the next slide. Looks like my slides are not advancing. Let's see. Okay. Nothing to disclose. Okay, overview. So this is what we are going to discuss this morning for me and evening for you all. So an overview of pulmonary hypertension in preterm infants, the epidemiology of pulmonary hypertension in BPD, the pathogenesis and cardiovascular anomalies that can contribute to pulmonary hypertension, the diagnosis and biomarkers, the therapy, the potential approach to pulmonary hypertension in BPD, the long-term effects of BPD and pulmonary hypertension, and finally some concluding remarks. So this is not anything that's new. So you all know that back in 1967, 53 years ago, BPD was described for the first time by Northway, Rosen, and Porter in 1967 in the New England Journal of Medicine. And a few years after that, in 1976, his colleague, Dr. Bonikos, described pulmonary fibrosis, necrotizing bronchiolitis, and pulmonary. So they looked at the histology of 21 infants who died of BPD, and they found that 6 of those 21 had signs of cardiac stress, including pulmonary. So on the right, you can see what looks like a circular structure with a lot of thick wall, and that's actually a pulmonary artery with a lot of vascular remodeling. So this is not anything new. This is something that's been known for a long time, but it's not something that people think about. We just think of lung fibrosis or inhibition of lung development. We don't really think too much about vasculature. So when do preterm infants have pulmonary hypertension? If you are to measure the pulmonary pressures in any preterm infant with significant lung pathology, for example, a baby with severe respiratory distress syndrome and hypoxic respiratory failure, that's HRF, you will find that they have elevated pulmonary arterial pressures. You don't call it PPHN because generally PPHN is a term applied to term babies, but any infant with significant lung pathology would have an elevation of pulmonary arterial pressure. You can also have an increase in pulmonary arterial pressure in infants who are born after prolonged premature rupture of membranes and oligohydramnios. And some of these infants actually end up having something what is called as a dry lung syndrome, where they may have elevated pulmonary pressures for the first day or two. If they have severe oligohydramnios, the magnitude of pulmonary hypertension may be even more prolonged. Sometimes medications such as maternal NSAIDs or neonatal ibuprofen can cause premature closure of the ductus arteriosus, or can cause decrease in prostaglandin production in the neonatal pulmonary circulation, causing pulmonary hypertension. There are case reports of neonatal ibuprofen actually causing pulmonary hypertension. But what we are going to focus on today is looking at pulmonary hypertension in the setting of BPD. So if you look at a recent systematic review of pulmonary hypertension in extremely preterm infants, this is looking at all the infants without BPD. So that is, if you don't have BPD, overall your rate of pulmonary hypertension is extremely low. That is 0.02 is a proportion, or about 2% of these infants, so extremely low. It's not that it doesn't happen, but it's extremely unlikely. What about mild BPD? If the infant has mild BPD, the proportion is 0.04, about 4%. So slightly higher, but still more than 95% of the infants don't have pulmonary hypertension. What about moderate BPD? If you have moderate BPD, the risk increases from 4 to 8%. So it's a doubling of the rate. So no BPD, it's about 2%. Mild BPD, it's about 4%. Moderate BPD, it's about 8%. What about severe BPD? It's not 16%, it's actually a lot more. It's closer to 40% or 0.39. So it's only with severe BPD do you have a substantial number of infants with pulmonary hypertension. So 0.39 or about 40% is a pretty substantial number. That means 4 out of 10 infants with severe BPD will have pulmonary hypertension. The very first prospective cohort of our study was from our group at University of Alabama at Birmingham. The first author was Ramachandra Bhatt, one of our fellows. And we looked at 172 extremely low birth weight infants consecutively, and of them we were able to screen 145 of them by echocardiogram, starting at 4 to 6 weeks of age, and then subsequent ones at monthly intervals. Of this 145, we found that 9 had pulmonary hypertension at initial screening, but 136 did not. So of this 9 with pulmonary hypertension at initial screening, that is about a month of age, 5 of them still had persistent pulmonary hypertension at discharge. So more than half of them still had pulmonary hypertension when they were going to go home. And 3 of them had resolved pulmonary hypertension after they received oxygen or other therapy. And 1 of them actually went home even without any specific treatment. Of the remaining 136 who did not have pulmonary hypertension in initial screening, 17 of them were subsequently diagnosed with pulmonary hypertension, usually around 3 months of age. And most of these infants also had persistent pulmonary hypertension at discharge, and some of them also died. So of the 10 who had persistent pulmonary hypertension at discharge, 7 were discharged home on oxygen with medications, 1 on oxygen but without other medications. Okay, so what were the risk factors for pulmonary hypertension? So if you look at the regression analysis, adjusting for gestational age, sex, oxygen, and mechanical ventilation on day 28, the variables which were important were birth weight. So as the birth weight increased, the odds ratios decreased. So larger infants are less likely to develop pulmonary hypertension. Also, if the infant was growth restricted, SGA, they had a higher risk. So either the birth weight could be higher just because of the infant is AGA but a larger birth weight, or the infant is in SGA and it is at a higher risk. So a lower birth weight either because of just lower gestational age or because of being SGA is an increased risk factor. We think that is because of decreased nutrition. If you don't have sufficient nutrition, your lungs don't grow, and if your lungs don't grow, the blood vessels in your lungs also don't grow. So nutrition is critically important to the growth of your blood vessels in the lungs. So ideally, baby should have a larger birth weight and should not be SGA. And it's also quite evident that infants who need more oxygen or who are on mechanical ventilation are at higher risk. So the odds ratio adjusted is about 5 if you're needing more than 40% at day 28. And it's also higher if they're on mechanical ventilation at day 28. But look at that, the odds ratio is actually higher for oxygen than for mechanical ventilation. So oxygen need is actually a stronger predictor. And what about management of these infants? Most of these infants, like I said, required some management, just more oxygen and using a higher oxygenation threshold, which we shall discuss soon. Some of them needed sildenafil or nitric oxide. And a few rare infants needed additional therapy, such as bosentan, which is the endothelin blocker, or epoprostenol, which is a prostacyclin. Peter Murani from Colorado has also done quite a lot of work on pulmonary hypertension and has done a lot of prospective studies. And he screened infants with echocardiograms starting at 7 days of age. So now we are talking about screening with echocardiograms when they are still in the acute phase of RDS, or still in the RDS phase.
Sorry to interrupt. I mean, we are getting some interference on the slides. As you move, the background is moving. Is it possible to turn off the background to none?
Oh, okay. I will do that. Just a second.
Because I don't know if it's related to that, but it's possible when you're moving. That's also.
Let me see.
If you right click under the camera icon, you can say background.
Yeah, or I can just, maybe Yasser could just turn off my video. I mean, I don't see.
No, it would be better if you can turn off because it would be nice to see you.
Oh, okay. Wait, let me see.
Next to the camera icon, you can say background none.
Yeah, I don't see it. Wait, for that, I will have to.
In the Zoom video thing.
Yeah, I'll have to minimize the screen. 1 second.
No.
Okay, 1 second.
In the Zoom camera, I mean.
Yeah,
Zoom
got it. Okay, is that better?
Yeah, it's fine.
Okay, let me see if I can get back to. Oh, wait, okay, here we are. Okay. Are you seeing my screen again?
Yeah, screen is back. Yeah.
Okay, good. Okay, so this is the work done by Peter Morani, who showed that echocardiogram done at 7 days of age showed pulmonary hypertension in about 42% of the infants. And this was a risk factor for both late pulmonary hypertension as well as BPD. And if you do an echocardiogram at 36 weeks post-menstrual age, that is when you normally diagnosed BPD, about 14% or 1 in 7 infants had pulmonary hypertension. So if you look down here, you can see that if the infants had severe BPD, the rate of pulmonary hypertension was about 30%. If they did not have BPD, it was much lower at 16%. And in this cohort, the rate of severe BPD was about 19%. If they had early pulmonary hypertension, they had a higher risk of late pulmonary hypertension of about 21%. If they did not have early pulmonary hypertension, the risk of late pulmonary hypertension was lower. So what criteria are used for diagnosis of pulmonary hypertension? So obviously, if there is a bidirectional or right to left shunt, either at the PDA or at the PFO or ASD or at a VSD, that would be suggestive. Or if you can quantitate a right ventricular systolic pressure of more than 40, such as using a tricuspid regurgitation velocity, or if you have a ratio of the RV systolic pressure over systolic blood pressure of more than 0.5. But what's most common and what's probably more clinically relevant is septal wall flattening. So the highest sensitivity of diagnosis of pulmonary hypertension is if you can identify any septal wall flattening that is either mild, moderate, or severe. So this is just a graph showing the different rates of diagnosis using the different criteria. So the black bars are using any septal wall flattening, and the grayer bars are the ones using different thresholds. So the highest sensitivity is using any septal wall flattening. And how accurate is echocardiogram? We'll come to this again, but if you take multiple echoes from multiple patients and you give them all to different pediatric cardiologists, how likely are they to agree upon the presence of pulmonary hypertension? So overall, it's pretty good agreement. So it's about 82.9% agreement on the presence of pulmonary hypertension. So that is most of the time they would agree with each other. And what happens if you read an echocardiogram today, then you come back to the same echocardiogram, say next week, what is the probability that you will agree with yourself? What is the intra-rater agreement? So that's also pretty good, 92%. So there's a pretty good inter-rater and intra-rater agreement for diagnosis of pulmonary hypertension. We shall come to this in a little more detail later, but basically, even though people agree that yes, pulmonary hypertension is present, it's hard to define the magnitude of pulmonary hypertension. So what are neonatologists doing? So this was an electronic survey of neonatologists in American Academy of Pediatrics. So there were 306 responders of 2,500 neonatologists. So one thing we can immediately learn is that neonatologists don't like to answer surveys, only 12% response. But of the people who did respond, about 38% have an institutional screening protocol. This was about 3 years ago, so right now the numbers are probably a little bit higher. And most people would screen only if the infant needed mechanical ventilation or oxygen at 36 weeks. And some people did not screen any infants. But most neonatologists who are practicing for more than 5 years have noticed that the numbers of these infants are increasing, perhaps because we are increasing our survival of all these infants with severe BPD. 45% of people had also noticed pulmonary vein stenosis in association with BPD, and 90% of neonatologists had used anti-pulmonary hypertensive medications. But there's a lot of variation between different centers. So the gray bars are the rates at which people do echocardiograms, and the black bars are the rates at which pulmonary hypertension is diagnosed. So you can see there's a wide range in the rates of echocardiogram and a wide range in the rates of pulmonary hypertension diagnosis. But there is no correlation between center prevalence of pulmonary hypertension and the use of echocardiogram, telling us that other factors are probably playing a part. There is also a lot of variation between centers in what people do. Some people use a lot of nitric oxide, some people use a lot of sildenafil, but again, there's a lot of variation between centers. And there's no correlation between center prevalence of pulmonary hypertension and the use of either nitric oxide or sildenafil. Let's go down to the basic pathology and the pathogenesis. So people think of BPD as just an immature lung on which you have mechanotrauma, that is ventilation-induced lung injury and hyperoxia-induced lung injury. But actually, it's a little bit more complex. So you have an immature lung, all right, but then you have various genomic factors, various environmental determinants, volume trauma, infection, impaired nutrition, hyperoxia, fluid overload, and all that. You had all listened to the talk on BPD and PDA just a little while ago, so this must be familiar. And this leads to various intermediate phenotypes, inflammation, apoptosis, atelectasis, which leads to inhibition of lung development and abnormal lung vascular development, resulting in long-term impairment of lung function and pulmonary hypertension. So this is just a picture from human lungs, both normal on the left and BPD on the right. So you can see all these small alveoli, that's normal. But here in BPD, you can see that these alveoli are much larger. So that's basically the lungs are being fixed in the saccular stage. You don't have true alveoli. You're seeing much less alveolar septa being formed. And you can look at this arrow pointing to this blood vessel, which is much thicker. And you can also look at this airway, that's the bronchiole. You can see that the airway epithelium is showing necrosis. So the blood vessel is also showing thickening, suggesting that this infant probably had pulmonary hypertension. But what happens to the microvasculature? So previously, people used to think that there's inhibition of microvascular development. But if you actually do quantitation on autopsy lung sections, you actually find that there are more endothelial cells in these long-term ventilated patients compared to age-matched late controls. So there is an increase in the microvasculature, but it is dysmorphic, not deficient. So there are different patterns of angiogenic growth factors compared to normal. So it is dysmorphic and dysregulated. It is not just deficient. So there are more blood vessels, but they're not where they should be. There are also what we call IAVs, that is intrapulmonary arteriovenous anastomotic vessels. So this was shown in a very excellent detail by Dr. Steve Edmonds' group. So these are like 3D reconstructions of the normal perinatal lung as well as the BPD lung. And you can see that normally you have the pulmonary artery which takes blood to the lungs. The blood goes through the alveoli, becomes oxygenated, and comes out through the pulmonary veins. But what happens with these intrapulmonary arteriovenous anastomotic vessels is that it's a direct connection between the pulmonary artery and vein. So the blood bypasses the alveoli. It's basically an intrapulmonary shunt, leading to hypoxemia due to the shunt. So you could try adjusting your mean airway pressure, try adjusting your FiO2, you could try doing all those things. But basically, if you're having an intrapulmonary shunt, all those maneuvers are not likely to help, and this infant may have persistent hypoxemia. What is the rate of cardiovascular anomalies contributing to pulmonary hypertension? So this is a retrospective review of only a few patients, 29 patients with BPD and pulmonary hypertension. 2/3 of these infants, that is 19 out of 29, had cardiovascular anomalies. And what kind of anomalies were they? 9 of them had aortopulmonary collaterals, that is large collaterals directly from the systemic circulation to the pulmonary circulation. 7 of these 29 had pulmonary vein stenosis. 4 had large ASDs, and 9 had a hemodynamically significant PDA. Right now, there is a lot of, I would say, emphasis on developmental origins of disease. There is a lot of these things are not postnatal events, but they actually start well in the intrauterine period. So maternal PIH and severe growth restriction, I mentioned earlier that severe growth restriction or SGA is a risk factor for BPD and pulmonary hypertension. But we know that if the placenta is bad, that is, if there is maternal vascular underperfusion and reduced placental villus vascularity, if the placenta doesn't have too many blood vessels, then the baby's internal organs, including the lung, also have fewer blood vessels. There are multiple biomarkers in the cord blood which can indicate that there's maternal vascular underperfusion, such as placental growth factor, GCSF, which predict pulmonary hypertension. People have done metabolomic studies too, which have shown that various metabolites are consistent with fetal growth restriction in the infants who later develop pulmonary hypertension. So you could pretty much predict which infants are at high risk of developing pulmonary hypertension even close to birth. So can we actually prevent pulmonary hypertension in the setting of BPD? This was a recent retrospective chart review of 252 extremely preterm infants who underwent echocardiogram prior to discharge. So from 2012 to 2015, they used a lower saturation limit of SpO2, that is 88 to 92%. But in the most recent years, 2015 to 2016, they used a higher threshold, 90 to 95, from the support trial. And it was seen that the higher SpO2 group had a lower risk of pulmonary hypertension. The hazard ratio was 0.5. So they had only half the risk of pulmonary hypertension. But they also had a lower rate of elevated pulmonary vascular resistance, again hazard ratio of 0.55. The time to pulmonary hypertension development was shorter in the lower SpO2 group than in the higher SpO2 group. That is, if you keep your saturations lower, it's more likely that there will be some pulmonary vasoconstriction, and these are more likely to develop pulmonary hypertension. And these are some graphs from the paper. The blue line are the ones with a low saturation threshold, and the red line is the ones with a higher saturation threshold. And the y-axis, basically, the top two graphs is the risk of pulmonary hypertension, and the bottom two graphs, the rate of the pulmonary vascular resistance. And you can see that the rates are much higher in the infants with the lower saturation threshold. We talked about this briefly, about a diagnosis of pulmonary hypertension based on echo. So it's quite sensitive, about 80% sensitive, but the magnitude of pulmonary hypertension is difficult to determine and is not very accurate, because less than 10% of these infants actually have a tricuspid regurgitant jet. So if you don't have a TR jet, it's hard to have good quantitation. But there is pretty good agreement among cardiologists as to whether or not pulmonary hypertension is present. So there are some centers where cardiac cath is being increasingly used. And you would need to do cardiac cath, especially if you're suspecting pulmonary vein stenosis, left ventricular dysfunction, or if you want to do vasoreactivity testing to oxygen or nitric oxide. There are many centers which also do biomarker testing, which may help in early diagnosis and following the course. What I use at my institution is a BNP, which is B-type natriuretic peptide, which is elevated in BPD, pulmonary hypertension, and is associated with mortality. Important to remember that BNP basically is an indicator of ventricular stretch. It doesn't tell you that the infant has pulmonary hypertension. It just tells you that one of the ventricles is being stretched. So you could have elevated BNPs even with just a PDA. Remember that if you have a PDA, it's a left ventricle which is taking the strain, and so you would be having a left ventricular dilation. With pulmonary hypertension, you would have right ventricular dilation. So regardless of which ventricle is being dilated, you would have elevation of BNP. There are some research papers which tell us that ADMA, or asymmetric dimethyl arginine, is increased in infants with pulmonary hypertension. There's an increase of rate of endostatin to angiopoietin-1 in these infants too. There are also more pro-inflammatory cytokines such as IL-6, IL-8, IL-10, and so forth, and TNF-alpha. But again, these are not things that we measure routinely. The BNP is one of the things that we can measure routinely. If you are doing cardiac cath, you can do AVR, that is acute vasoreactivity testing. That is, while you're measuring the pulmonary vascular pressures and pulmonary vascular resistance, you can expose them to 100% oxygen, or you can add nitric oxide or take off nitric oxide. And the infants who have a better prognosis are the ones to show that they are still vasoreactive. So early in the course, most of these infants are vasoreactive, and if you give them more oxygen or nitric oxide, they're able to vasodilate. But if you have a fixed component of the pulmonary hypertension, then it's a worse prognosis. There are various guidelines that the American Heart Association and American Thoracic Society have come out for BPD and BPD with pulmonary hypertension. And they basically state that screening for pulmonary hypertension is recommended in established BPD, and that you need to evaluate and treat lung disease, including trying to fix the known problems such as hypoxemia, aspiration, structural airway disease, and so forth, before you start treating the pulmonary hypertension. That is, until you fix the underlying problem, trying to fix pulmonary hypertension isn't all that useful. And obviously, you want to identify disease severity and potential contributing factors such as diastolic dysfunction, pulmonary vein stenosis, and so forth. Now, important to remember that most of these guidelines are class 1, in which benefits are probably more than risks, but the level of evidence is usually a class B, meaning this is from a single randomized trial or multiple non-randomized studies. So these are not data from multiple randomized trials. So this is not high-level data. And this is the algorithm developed by Tracy and Cornfield, again showing what's a potential way to manage these infants. That is, you could do an early echocardiogram if the infant is on high ventilator settings or on oxygen and it's not improving quickly, or at 36 weeks if they're still on a ventilator, poor growth and elevated CO2. And then you could, if they do have pulmonary hypertension, you've got to evaluate and treat lung disease, and you could follow it with echoes and BNP. And if you have ongoing pulmonary hypertension, then they would suggest a cardiac cath. Currently, though, most people would try one vasodilator or maybe two vasodilators before going to cardiac cath, because the experience of cardiac cath is kind of limited in these small infants with BPD and pulmonary hypertension, and many of them are medically fragile, and it's quite risky to take them to the cardiac cath lab. But anyway, we need a multidisciplinary team of neonatologists, pulmonologists, cardiologists, and pulmonary hypertension specialists to be involved in the care of these infants. And obviously, you would need a screening echocardiogram for multiple types of infants, like we had discussed earlier. So what should you look at in the echocardiogram? It should include a complete anatomic evaluation to identify and characterize the physiologic contribution of structural abnormalities, shunts, and pulmonary veins. Should assess the right and left ventricular sizes, hypertrophy, systolic and diastolic function. And importantly, should look for the septal positioning. Is it flattened? Is it bulging into the right ventricle or bulging into the left ventricle? And if there is any tricuspid or pulmonary regurgitant jet, the velocity should be measured. And obviously, you should need a simultaneous systemic blood pressure documentation to find out what it is in relation to the pulmonary pressures. They also recommend that biomarkers like BNP or pro-BNP can be measured. And obviously, you need to evaluate and treat comorbidities. In selected cases, cardiac cath should be performed, and they actually recommend prior to the addition of combination drug therapy. That is, if you are giving one agent and the infant does not respond, before adding a second agent or third agent, you want to take the infant for a cardiac cath. Especially because if the infant has, say, pulmonary vein stenosis, what would happen if you start that infant on nitric oxide? So nitric oxide is a pulmonary vasodilator. So if you increase your pulmonary blood flow in the setting of pulmonary vein stenosis, you would cause more pulmonary edema in the infant. So you would actually make the infant sicker. Or suppose the infant has left ventricular dysfunction. So if you give that infant nitric oxide, again, you'll be increasing pulmonary blood flow, but blood flow is not going to get back through the heart quite as easily because of the left ventricular dysfunction. So it is important that if the infant is not responding to drug treatment, to do a cardiac cath to see if there's any underlying problem, especially pulmonary vein stenosis or diastolic dysfunction. It is recommended that oxygen saturations be maintained between 92 and 95% in patients with established BPD and pulmonary hypertension. So similar to what Dr. Vineet Bhandari mentioned in the previous talk, we set our alarm limits between 88 and 95, with the goal between 90 and 95 in preterm infants. But suppose the infant develops pulmonary hypertension, then we reset the limits slightly higher. So instead of 91 to 95, we set it as 92 to 95 or 92 to 96. So we set the alarm limits at 91 to 97. So your target range is one less so than what the limits are, because you don't want the alarms to be going off all the time. So if you set the alarm limits between 91 and 97, you're basically targeting 92 to 95 or 92 to 96%. So nitric oxide should be used for acute pulmonary hypertensive crisis and weaned after stabilization. And what we usually do is, once they start nitric oxide, we give it for a week or so. And if the infant is showing improvement, then we add sildenafil therapy. I'll come to the doses in a little while. pH-targeted therapy should be considered for infant BPD and sustained pulmonary hypertension after optimal treatment. These infants should have outpatient follow-up. So just because we as neonatologists take care of these infants doesn't mean that once they go home, they are fine. Most of these infants, like I will discuss briefly, will still have persistent problems. They need to be followed up by a specialist. So therapy of pulmonary hypertension in preterm infants. So the important caveat here is, as I've shown here with this yellow diamond, is there's a lack of evidence for most of these things. So we really need more hard data on management. What we are going to be talking today is about management of pulmonary hypertension and BPD. As I just mentioned, it's management of BPD, oxygen therapy, minimize hypoxia, and specific vasodilator therapy if needed. Oxygen therapy, like I mentioned, keeping saturations a little higher would reduce hypoxic vasoconstriction. And you want to avoid factors which can cause hypoxia, such as bronchospasm. Pulmonary vasodilators are of unknown efficacy. I mean, they work in animal models. They work if you are doing a cardiac cath and you can show that they cause vasodilation. But what is their long-term effect? That we don't really know. There are multiple agents, nitric oxide, prostacyclin analogs, bosentan, there's also ambrisentan and citaxantan, which are selective endothelin A receptor blockers, various cyclic or the cyclic GMP agonists, or things which increase cyclic GMP, like soluble guanylyl cyclase stimulators such as riociguat and sinaciguat. But many of them are still experimental in this population. So again, you can affect the prostacyclin pathway, you can affect the nitric oxide pathway, or it can affect the endothelin pathway. There are three major pathways affecting pulmonary vasomodulation. As I briefly mentioned, use of pulmonary vasodilators may be detrimental in an infant with cardiopulmonary anomalies. So if you have pulmonary vein stenosis, cytopulmonary collaterals, or left ventricular dysfunction, and you use nitric oxide or prostacyclin, then they may get worse because they're increasing pulmonary blood flow but not increasing outflow. So cardiac cath may be necessary in these infants. So if you don't have the facilities to do cardiac cath in many of these infants, you can start the vasodilator, but carefully monitor them afterwards to make sure they're not getting sicker. If they do get sicker, then you probably need a cardiac cath. The pulmonary vasodilators that are commonly used, sildenafil, we usually start at a lower dose and increase slowly. And generally, we max out at 10 milligram Q 8 hours. That is not more than 30 milligrams a day, regardless of the weight of the infant. There are known side effects, but fortunately, they are quite rare in this population, especially for the larger BPD infants. Bosentan is a drug which is quite toxic. These infants need to be monitored for liver dysfunction and anemia, so they need to be monitored for liver function tests and CBCs weekly. Iloprost, epoprostenol, again, experience is quite limited. Very few centers use them. Milrinone obviously needs an intravenous line and can cause hypertension. So we don't use it unless the infant already has existing IV access or is critically ill. The most evidence is with sildenafil. There have been multiple studies done, no serious adverse effects reported. However, you got to remember that these infants with BPD and pulmonary hypertension, they have extremely high mortality. So it's really hard to say what the long-term effects are with sildenafil because a large number of these infants die because of their underlying lung disease. The ones who do survive show improvement in pulmonary pressures and respiratory scores. So potential approach to pulmonary hypertension, what we do is we do early identification. We screen all preterm infants less than 29 weeks with an echocardiogram at about a month of age. And then at monthly intervals, if they're still on a ventilator or CPAP or needing a lot of oxygen. And we occasionally do a cardiac cath if they don't respond to one agent at high doses or to two agents. Risk stratification, again, like I mentioned, it's possible to identify which infants are at higher risk. There is the infants who are smaller, more preterm, more growth restricted, and needing higher settings. And the better understanding of the pathophysiology may lead to development of new therapies, optimizing existing therapies, or personalized therapies. And we really need more randomized trials to evaluate existing experimental therapies and future therapies. So there are a lot of potential therapies, but we don't necessarily know how well all of them work. So the natural history in this study published a year ago, of all infants with the BPD, most of them severe. Mortality is associated with increased severity of pulmonary hypertension, and pulmonary pressures are higher in those who died. And at follow-up, 1/3 of these infants are still on pharmacologic therapy or oxygen, though 2/3 apparently had resolution of the pulmonary hypertension at about 3 years of corrected age. This is another study published this year of 101 patients with BPD pulmonary hypertension, about 100 of them being treated with sildenafil, some of them with bosentan and other agents. About 1/3 of these infants died during the study period, and of this third, 1/3 of them were secondary to severe pulmonary hypertension. And at about a follow-up of about 5 years, it is seen that only a quarter of them were still on medications. 77% were weaned off pulmonary hypertension medications at about 2 years of age. Intermediate term impact. So this is a study from the Children's Hospital National Consortium. So this is a large sample size, about 1,677 infants, less than 32 weeks. Pulmonary hypertension was seen in about 22%. As would be obvious, it's associated with higher mortality, more ventilator support, and so forth. More of these infants need tracheostomy, about 27% versus 9%. 84% needed supplemental oxygen. More of them needed tube feeds and so forth. And these infants are at higher risk of being readmitted. Long-term impact. At 1 year of age, they still have abnormal pulmonary vascular disease. And even if you look at them at school year, that is 11 to 14 years of age, if you look at babies who are born preterm versus term, the preterm infants had greater tricuspid regurgitant velocity, and the infants who had BPD as preterm infants had a higher tricuspid regurg velocity compared to preterm no BPD infants. So a term baby, assuming they're normal, is 1.95. Preterm no BPD is 2.15, and preterm BPD is 2.25. So even infants without BPD still have abnormal pulmonary vasculature. And what happens to babies who are born preterm and who don't have BPD, who are doing fine otherwise? So if you look at them as young adults, so this is by Cara Goss. So she took young adults who are very low birth weight, average gestational age 28 weeks as infants, and she did a cardiac cath on them, at least a right heart cath. And she found that 3 out of these 11 young adults had borderline pulmonary hypertension, and 2 out of 11 had overt pulmonary hypertension. And their parameters indicated stiffer pulmonary vasculature, and they were less able to augment cardiac index. So even if they are not on oxygen, if they're not on medication, all our preterm infants, when they become young adults, they are likely to have some evidence of pulmonary hypertension. So it's not something that becomes totally normal. They do have some persistent abnormalities. And what happens to them as adults? So if you had to do cardiac MRI in adults 20 to 39 years of age, in kids who are 30 weeks at birth, they have a greater LV mass. I mean, you know that preterm infants are at high risk of systemic hypertension. And they also had a greater right ventricular mass and lower right ventricular ejection fraction. So again, even as young adults, they have abnormal hemodynamics. So in conclusion, all our operational definitions, I mean BPD and pulmonary hypertension, they don't capture the phenotypic and genetic heterogeneity underlying pathogenesis. Pulmonary hypertension occurs in a fifth of extremely low birth weight infants, primarily those with moderate or severe BPD, but it can happen even in infants who do not have BPD. And it persists to discharge in many infants, and it can actually persist even into childhood or young adult life. We don't know what happens when they are 40 or 60 years old because we haven't really followed up infants that long. Generally, by echocardiogram, and some infants may need cardiac cath, especially if they don't respond to vasodilators. Reduction of pulmonary hypertension is possible, but we need to implement proven interventions such as antenatal steroids, more use of CPAP, caffeine, vitamin A, good nutrition. As I mentioned, nutrition is critically important to lung development and lung vascular development. We also need more evidence on common interventions. We need to do randomized trials on diuretics, bronchodilators, PDA management. There's still a lot of controversy over the PDA, as from the talk earlier today. Do we know if diuretics work long term? Do we know if bronchodilators work long term? We don't know that, yet a lot of people keep using them. We need evidence on therapies currently used for pulmonary hypertension. What's the long-term effects of sildenafil, nitric oxide, and so forth. We need better analysis of long-term outcomes. And we need careful QI processes and monitoring of outcomes, because we want to make sure that just because somebody has a problem, we start therapy and we think that we are doing good, but we want to make sure that things actually don't get worse. So we need to make sure that outcomes get better, not worse. So there are some questions that need to be answered. Do all infants with BPD have abnormal pulmonary vasculature? That's probably true. Is pulmonary hypertension just a threshold effect? That is, by our definition. Are we just detecting vascular remodeling beyond a detectable threshold? How much of it is fixed versus how much is dynamic? And do all preterm infants have persistent abnormalities in the pulmonary vasculature? And how should we monitor them? Who's going to monitor them? And is there a different genetic basis for these infants to develop pulmonary hypertension versus those who just have BPD? And what specific prophylactic or therapeutic strategies can be used to prevent or treat BPD? So a lot of unanswered questions, but I think we are making progress. I think I can stop now. There are a lot of ongoing research, such as cardiac MRI, various new biomarkers, and so forth. But it'll probably take another 5 to 10 years before we actually start doing any of those things. Thank you.
Okay. Thank you, Dr. Ambalavanan. This is really a very interesting lecture. I think a lot of practical issues as well. So I think we are open for questioning. Anyone has any question? I believe there was one question here with me. Can INO be used in preterm infants?
There have been multiple trials of INO in preterm infants. INO does not work for prevention of BPD. So using nitric oxide prophylactically does not seem to help human preterm infants. It seems to work in animal models, but hasn't really been shown to work in human infants. There's just one study by Mike Schreiber from Chicago, which showed possible improvement in the subpopulation. But all the other studies, such as the European nitric oxides trial, the UNO trial, did not show any benefit. However, what we are focused on is, would nitric oxide work in infants with BPD and pulmonary hypertension? That is, we're not talking about preventing BPD, but about the infants who already have BPD and who have pulmonary hypertension. We have done some studies in which we have exposed these infants to nitric oxide and then followed them up, and many of them have a reduction in pulmonary pressures. But again, these are case series or retrospective cohorts. There have been no large randomized trials to show that there is long-term benefit. But people still use nitric oxide, at least initially, for management of pulmonary hypertensive crisis in this population. And they usually transition them to sildenafil in about 2 weeks.
Thank you, Dr. Ambalavanan. It was a very interesting talk, and obviously the figures in the article published this year are not very promising in the babies with well-established BPD beyond 36 weeks. We had a similar case recently where the baby had a significant PDA, but the treatment was delayed, and around 35 weeks corrected age, the PDA was ligated, and that actually led to some worsening of the condition. So are we better off, starting steroids maybe to reduce the lung disease rather than treating the PDA at this stage with the ligation? Because it seems like the circulation has made some adaptation. And then the baby, baby passed away ultimately, even though we struggled, did not respond to any of the treatment. We didn't do a cardiac cath, but we had a trial with both sildenafil and bosentan, and we had multiple doses of steroids in desperation, but didn't make much difference. It was fibrosis on the X-ray as well. It's like old BPD.
Yeah. Yes, I think even though people call this as old BPD and new BPD, I think we still see a lot of the old BPD. It's not like it's gone away. We still see a sufficient number of infants with overlap between the inhibition of lung development and the fibrosis. And I agree that many of these infants are very hard to take care of. You don't want to end up ligating all infants with a PDA, but at the same time, if you have an infant with severe BPD and a large PDA, which is hemodynamically significant, we may need to consider doing something about it before the infant develops cor pulmonale, because then once you have right to left shunting, then it's hard to fix. Sometimes what our cardiologists do is they take them to the cardiac cath lab and they use one of these device closures temporarily. So you can put in the device, blow up the balloon, close the PDA, and see if it helps the hemodynamics. If the infant gets worse, then you can basically stop trying to ligate the PDA or stop trying to close the PDA. If it looks like the infant benefits, then you can probably do that. Also important to remember that many of these infants in whom you try to close the PDA later, remember that the left ventricle will decompensate after you close the PDA, because the left ventricle has become used to pumping against a low resistance circuit with the open PDA, and now suddenly close the PDA, the left ventricle can't pump against a much higher systemic resistance. So you can have decompensation of the left ventricle, and then these infants get sicker. So most of these infants end up needing a lot of milrinone for the first week or so post-ligation.
Okay, I think there is one interesting question from Dr. Avijit Singla. He thank you for the informative talk, and he's talking that the echocardiographic criteria for pulmonary hypertension mentioned by you can be used in early days of life. What about the echo criteria for pulmonary hypertension in established BPD, since it is hard to, hard to find special flattening and shunt across the duct or PFO in really corrected term babies of 36 to 38 weeks? Do you get the question, probably?
Yes, I think most cardiologists still use the same criteria. It's a little harder to look for those things, but I think they still use the same criteria. I think the septal flattening is one of the more sensitive criteria. Most of the time, you don't really see much shunting in these infants. I mean, because most of these infants with established BPD, you have intrapulmonary shunt, you don't necessarily have intracardiac shunt.
Okay, one more question. What is the right age for tracheostomy for BPD patients? And can it be, can it impact any development of pulmonary hypertension BPD?
That's a very complicated question about when a tracheostomy is indicated. If you ask 6 neonatologists, you will get 20 opinions because
yes, that's correct.
It depends a lot on the infant. I think doing a tracheostomy before 3 months of age is too early, and I think waiting to 1 year of age is probably too late. So it's somewhere in the middle. Most neonatologists I've seen, most centers, there's a lot of variation from one center to another. I think the earliest I've seen is starting at around 4 months of age and going on up to 6 to 8 months of age. And I think the question about whether it actually impacts development of pulmonary hypertension, probably not. I think what a tracheostomy does is it helps improve airway management. It doesn't really fix the underlying lung problem. But it might also improve the ability of you to interact with the infant as the infant gets older, close to 1 year of age.
Thank you. I mean, in terms of the angiogenesis that you mentioned and the shunting, I mean, is there anything we can do about that part?
Most of the dysregulated angiogenesis we think is secondary to inflammation. And this inflammation is often secondary to volutrauma or secondary to chorioamnionitis and infections. So again, the same things which help for BPD, that is preventing infections, preventing too much oxygen, preventing too much tidal volume, all those things also would help for better vascular development too. So nothing specific.
What about the retinopathy treatment with the bevacizumab?
Yes, so yeah, that's a good point. So the problem with ROP, again, like you mentioned, is abnormal angiogenesis in the retina. And the question is, what happens when you try to fix the blood vessels in the retina? How much of that anti-VEGF inhibitor actually gets into the circulation, and how much of it can affect blood vessel growth, say, in the lungs? Currently, I think the evidence is not very clear about how much of it gets to the lung. I think there is only a minimal effect on lung development. So I think if you have multiple doses of this bevacizumab, Avastin and other things for ROP, then there may be some effect on lung angiogenesis, but I'm not sure that's going to be a significant effect, maybe a small effect. I'm actually more concerned about beta-adrenergic agonists, things like either beta blockers like propranolol because they inhibit vascular development, or beta-adrenergic agents like albuterol, salbutamol, those kinds of agents, because they can also affect angiogenesis. And we don't know what their effects are on the lung angiogenesis. People need to study it, but nobody has studied it so far.
There's one more question that was asked to Bandari. We repeat that as well. I mean, what is the role of inhaled steroids in your view, and do you use them in your unit?
Inhaled steroids have not been shown to benefit pulmonary hypertension. They do reduce BPD to some extent, but if you look at this recent study by Basler et al. In the New England Journal, they reduce BPD, but they also increase mortality. So generally, most centers don't use prolonged courses of inhaled steroids. What we sometimes do is, if the infant has a high systemic steroid requirement, we sometimes give them inhaled steroids to reduce the amount of systemic steroids they need. Not inhaled steroids by itself, but more as an add-on to reduce systemic steroids. Sometimes we give inhaled steroids briefly, trying to get them over a brief episode of lung inflammation.
Thank you.